grand rounds today because we have Dr. Gelb here speaking to us. So I'm just going to read you a little bit about him and some of his accomplishments. Let's see, so Dr. Gelb, he's a board-certified cardiologist here at TIM. He graduated from the University of Miami School of Medicine in 1988, and then he completed an internal medicine residency in Los Angeles and a fellowship in cardiovascular disease at USC Medical Center. He's treated patients in California, Pennsylvania, Florida, and Utah. And his areas of expertise include invasive and interventional cardiology, including stenting, intravascular ultrasound, and Doppler flow wire. My voice is really shaking. Peripheral and angiography. There's lots of big words in this, Dr. Gelb. Pacemaker implantation and follow-up, non-invasive cardiology, including nuclear imaging, echocardiography, transesophageal and stress echocardiography. Oh my gosh, echocardiography. Consultative cardiology, including emergency and critical care disease management, phlebology and vein disease management, and hyperbaric oxygen supervision. Whew. He was born in Hartford, Connecticut, and grew up in Miami, Florida. He has enjoyed science since an early age, and he always wanted to be a doctor so he could make the world a better place. His care philosophy is an individualized approach to patient care focused on improving both quality and length of life based on science and clinical data. And a little personal bit about him, he's married with 4 children, and he enjoys skiing, hiking, fly fishing, and rock climbing. So,
Thank you for that long introduction. I've been doing this for too long, I think.
Is that one okay?
Your seat just gets longer as you're doing this. When I first joined the staff here a couple of months ago, the medical staff office asked me to give this talk. And what it really is kind of 2 talks in one. And each one of these topics could easily fill a grand rounds. And so what I did was I kind of crammed 2 talks into one talk. And I'm going to try to put it all together for you, both before, during, and after the talk. But I'm going to try to move through some of these slides fairly quickly and then leave some time for questions at the end. We're talking about bleeding and renal injuries resulting from invasive procedures. I'm referring specifically to cardiac catheterization and stenting, but this talk could easily apply to any interventional procedure. If you're an interventional radiologist, CT scans, or any interventional procedure, for example, peripheral vascular surgery or peripheral vascular angiography, and CT angiography in the radiology department. These principles basically apply regardless of what your specialty is. So I think it's a broadly important topic, but it's one that we as cardiologists deal with on a regular basis. And there's a lot of literature, primarily from the cardiology side, that's broadly applicable to all of those specialties. So this talk is on 2 things: bleeding and nephropathy, or dye-induced kidney disease. And while they're 2 separate topics, they have a lot of things in common. The first is that when they occur in patients in the hospital after a procedure, they are both extremely dangerous markers of impending death. So avoiding bleeding and nephropathy is very, very important. They have common risk factors, so people who develop nephropathy also are prone to develop bleeding and vice versa. And they're up to a point preventable, and I'll go through that in some detail. This is a CT scan of a patient who had a cardiac catheterization and suffered a major complication. This is a massive groin hematoma. You can see it's displacing some of the pelvic organs, and there's probably at least 5 units of blood in that thing. This is the kind of thing that we're going to try to avoid, and patients who suffer these kinds of complications have a death rate as high as 5 times people who don't bleed. So very, very important topic. The risk factors for bleeding are very similar to the risk factors for renal failure, as you'll see, and it's what you might expect. So it's the older patients, it's female patients, it's patients with pre-existing renal failure. So you have the 2 tie in, bleeding and renal failure. They tie into each other all the time. Prior history of bleeding and the use of both 2B3A inhibitors like integralin, as well as heparin, which should have been on the slide but was left out. But any blood thinner really is a risk factor for bleeding. So these are the ones to keep in mind. And unfortunately, these are the kinds of people that we take care of. So there's a saying in the legal profession that there's There's no swans in a sewer, and that's really true in medicine too. We don't take care of marathon runners. We take care of people who have kidney disease and bleeding histories and elderly, frail people. And those are the people that have heart disease. We don't get to choose who we take to the cath lab on an urgent basis, unfortunately. So unfortunately, the people who come in with emergencies, if you don't bring them to the cath lab, they're often going to die. And so even though they may have a very high risk of developing these complications, if you don't do anything, their chance of survival is virtually zero. So we're forced to take care of them, even though we don't necessarily want to. Those are the kinds of patients that we have to take care of. So people who bleed tend to die at an alarmingly high rate. So among all patients who come with acute coronary syndromes like unstable angina and MIs, your risk of death if you develop a significant bleed is as high as 3 or 4 times those patients who don't bleed. Now, most of these deaths are not due to bleeding, although some of them are. It's more the tendency to bleed that makes you more prone to die. So it's because of these patients' frailty that you worry about their risk. It's not the bleeding itself that kills them, although some people do bleed to death. Hopefully that's not happening very often in the hospital. So in one particular study, a very large trial of patients with unstable angina, patients who had a major bleeding episode were about 7 times more likely to die than patients who did not bleed, did not have any significant bleeding during their procedure or during their hospitalization. And this goes out to 35 days. So obviously, hopefully somebody wasn't in the hospital bleeding for 35 days. That would be probably a case of malpractice. So obviously, it's not just the bleeding. That would be a problem in the first week, let's say, in the hospital. But these patients go on to be extremely prone to having a bad outcome even after they've left the hospital. And you can follow this out even for 6 months, and patients who have significant bleeding have a higher mortality all the way out to 180 days. So this is obviously a sicker cohort of patients. So the question is, if you stop them from bleeding, will you reduce their mortality? And the answer is probably to some extent, but you can't control for the risk factors that led to that in the first place. And of course, what kind of bleeding you have makes some difference. So people, and this is just common sense, I think, people with life-threatening bleeds have a much higher mortality than people who have minor bleeds or no bleeds. So if you have a small groin hematoma or a little bruise or something like that, that's not anything significant. When you start having major bleeding problems, these patients go on to have very poor outcomes. The mortality rate here after a life-threatening bleed is 25%. But that's why it's called life-threatening, right? So in the acute coronary syndrome patient, which is the typical patient who's treated with aspirin, heparin, Plavix perhaps, 2B3A inhibitors, who goes to the cath lab and has a hole stuck in their artery. These are the kinds of patients that are the most prone to having bleeding episodes. And the point of this slide is that 2/3 of the bleeds that occur because of the instrumentation that we do at the access site, usually in the groin, more commonly these days in the wrist. But the point is that a lot of this is caused by us. We're causing some of this bleeding problem. It's not just spontaneous bleeding like GI bleeding or cerebral bleeding. These are patients who are bleeding because we're poking holes in them when they come into the hospital while they're being anticoagulated. So a lot of it is our fault. So it's really incumbent upon us to make sure that our technique and our attention to detail is very, very strict about preventing this from happening, because we're the ones who are actually causing it most of the time. So another cohort of patients, this is the patients with non-STEMIs. In patients who were at very low risk of bleeding, the bleeding rate was very low, and the risk score is based on various factors like age, gender, and the things we went over before. But as you can see, in patients who are treated conservatively, regardless of their risk, there's obviously a lot less bleeding. So if you decide to cath a patient, you're going to increase risk of bleeding just by the very nature of doing the heart catheterization in the first place. So when you decide to do a heart cath on a patient, you should really look at the patient and decide whether or not what you're doing is going to actually do them more good than harm. And that seems like a simple question, but it's actually not often very black and white as to whether a patient should be treated invasively or conservatively. I tend to be more conservative, especially as I've gotten older. I've done this for more years. I've gone to really respect how much harm we can do to patients by over-proceduralizing them, for lack of a better word. People who get too many procedures often have worse outcomes, and I think deciding how much is enough is a very challenging question. because we know that sometimes people benefit from these procedures, but we can also easily harm them. So just focusing on the procedural side of things briefly, some of the risk factors for causing groin bleeds, which is the most common bleed and the most common complication after heart catheterization, using a larger sheath, keeping the sheath in for too long, older age, patients with low platelet counts, patients who receive balloon pumps, patients who get a venous sheath. I don't put in routine venous sheaths anymore for this reason, and patients who have to have repeat intervention or repeat instrumentation. These are all technical risk factors as well as demographic risk factors for significant femoral complications. So the incidence of bleeding is about 5%. Transfusion requiring is less than 3%. These days, it's very rare for us to continue heparin after the procedure. We almost always stop heparin. So the heparin is given during the procedure, and it's almost always stopped and not continued after the procedure. That's probably been the biggest reason that there's been a reduction in bleeds in the last 10 or 15 years. The use of 2B3A agents like integralin, for example, or Riapro, has allowed us to use less heparin, and now we're finding that we can even eliminate the 2B3A agents and just give patients the newer antiplatelet agents like Brilinta, for example, and these patients do well with just a single slug of heparin and some oral agents, and we only use 2B3 agents provisionally. So reducing the use of these medications is a really important way to prevent bleeding from occurring. Being patient about sheath removal, I personally like to use a closure device, which works very, very well. But if you take the sheath out too soon, you can get more bleeding. That's just common sense. You want to keep your sheath size as small as possible. And ADP inhibitors are things like Plavix and Brilinta. We've really stopped using Coumadin in coronary artery disease. It's only used primarily for people with valves and atrial fibrillation. And the use of Coumadin is thankfully going down. Will hopefully disappear altogether one day as the newer anticoagulants come out. So we're hoping that newer drugs are going to help us solve this problem and reduce the incidence a bit. Reasons for complications, poor technique, multiple sticks, giving patients too many medications. If you think about it, a patient comes to the ER with chest pain, he gets heparin, he gets integralin, he gets aspirin, he gets Plavix, then I got to go and stick a hole in his leg. It's a perfect setup for a major bleeding complication. And then here we start seeing, once again, the same risk factors: female gender, obesity, low body mass, frail old patients, or patients with sort of round shapes. These patients often very hard to localize their arteries because of the way that they're shaped. Old age, and my favorite, of course, is bad luck. Whenever it happens to me, it's always bad luck. So one of the dreaded complications of cardiac catheterization is a posterior stick leading to a retroperitoneal hematoma. That's not bleeding in the groin, it's bleeding behind the groin into the abdominal cavity in the retroperitoneal space. If you do the stick too high, if you do a through-and-through puncture, patients will develop flank pain, abdominal pain, but they may just drop their blood pressure. And when this is one of the most dreaded complications of our procedure, of our groin procedures, and thankfully it's about 1% or less. When it happens, it's always an emergency. And of course, this is a retroperitoneal bleed here. There's a big collection of blood in the retroperitoneum. It's not obvious clinically because it's behind the patient. A few days later, after they're dead, they'll have a big bruise here. So you can't really, the only way you can tell that it's there is you have to suspect it. The patient drops their blood pressure for no good reason. You don't like to move them too much, so getting a CT scan is a luxury. I usually start giving them fluid and even blood before I'm even sure that they even have it. If they're hypotensive, you get very aggressive at volume resuscitation. And if there's any indication of bleeding at all, you want to give blood very quickly because these patients can exsanguinate and die very, very quickly. So I would be remiss if I didn't mention radial artery procedures, and the reason I do it reluctantly is because I was trained to use the groin, and I've tried doing radial artery procedures. I don't like doing the radial artery, but the incidence of major bleeding complications is virtually nil when you use the radial artery compared to about 2 or 3% when you do the femoral or brachial approach. However, you do end up with about 3% asymptomatic radial artery occlusions, which must not be a good thing, but apparently since they're asymptomatic, it's considered acceptable. But bleeding is virtually nil in this population. And so some of the younger guys coming out of training are doing all their procedures radially, And I have tried it. I haven't really liked doing it very much. And the main reason is that it's hard to get radial access sometimes. So the success rate of PCI using the groin is almost 100%, but it drops down significantly because about 5 to 10% of patients, you just can't get radial access. So I'm not sold on it yet, but I think that probably in the future we're going to start seeing more and more radial procedures and less femoral procedures, hopefully after I retire. So some of the hallmarks of hemostasis. Those of you who work in the ICUs, the CCUs, and the cath lab are probably familiar with some of these things. The gold standard has always been manual compression. Hold pressure above the puncture site for a good 15 or 20 minutes and watch it very carefully and make sure that you don't get a late bleed. I still do manual compression when I pull out balloon pumps. Mechanical compression devices I really don't like very much because I think once you put them on, people tend to kind of ignore the groin. The patient's not watched this carefully sometimes, and I've seen more problems with these external compression devices. And then the closure devices have made my life and the life of the nurses a lot easier. I prefer using angioseals. They're pretty reliable. They occasionally will pop out and you'll get a bleed. But angioseal means that you only need a couple of hours of bed rest after a catheterization instead of 6 hours. I do 4 hours after intervention rather than 6 hours. And it frees up the nurses and the cath lab staff to do other things instead of sitting there holding the groin for so long. But you got to be careful because these devices do not reduce your risk of having a groin bleed. They're just more convenient. So the risk is about the same compared to manual compression. So they've not demonstrated any reduction in major complications. It just makes things easier. They do cost a few $100, but I think that's money well spent because you're freeing up your staff to do other things than stand there and hold the groin. And certainly, I don't like doing that very much. I do it when I have to, like pulling out a balloon pump, but I try not to pull sheaths. I did enough of those as a fellow, and I don't like doing it anymore. But the AngioSeal is my particular favorite, but all devices are pretty good, and they're all about the same as manual compression in terms of complications. The patients like if they get out of bed early and they can get home earlier, especially for outpatient procedures. So the closure devices reduce time to ambulation, reduce time to discharge, improve patient satisfaction, and they can reduce costs, but you have to pay for them first. And so some cath labs choose not to use closure devices, and some cath labs do. So just to change topics here for a minute, we're talking about bleeding, and one of the things that's important is how do you define it? Because if you're going to study something like bleeding in large trials, you have to define what bleeding is, and each of these trials define bleeding differently, and so that makes it hard to compare trials. We sort of, I think, set on the TIMI score as the most reliable bleeding parameter, mostly because I think there was just a lot of money behind the TIMI research, and so that became the most popular, but I prefer some of these other ones. But you'll see that the trends are all the same, the principles are all the same, regardless of how you define bleeding. If somebody's having a serious bleed, it doesn't matter how you define it, you'll know it when you see it, because it's usually a serious problem. So in the Gusto trial, which was my favorite way of describing bleeding, you either have severe, moderate, or mild. If it's severe, it's either in your brain, or it causes hemodynamic compromise and requires intervention like a blood transfusion. If it's moderate, then it requires a blood transfusion, but it's not resulting in hemodynamic compromise. And if it's mild, it's none of those two. So that's pretty easy to define those three things without any numbers or labs or anything like that. Intracranial bleeding is always a severe bleeding complication in all of these. TIMI is a bit more complicated. It requires you to get labs and do math in your head, and 15% decrease in hematocrit, greater than 10% decrease in hematocrit, and then all of it bleeding. So this is a more well-defined way of doing it, but the principle is the same. You have major, minor, and minimal versus major, moderate, and minor. But basically, however you do it, the QD skips the moderate and just goes to either have major bleeding or minor bleeding. And again, it's just definitional. It's nothing you really have to memorize. It's just to show that there are different ways of assessing this. So if you look at independent predictors of major bleeding, all the trials end up showing you pretty much the same thing. And you've seen this all in the previous slides, but it's a different study showing the exact same thing. Advanced age, female gender, presence of diabetes, anemia, look at that, renal insufficiency. They all show up as the same risk factors. So these are patients who are older, sicker, smaller in size, tend to have thinner blood vessel walls, and so you can almost predict who's going to bleed, who's not going to bleed, if you know what to look for and who's more prone to having these things, having these complications. And the predictors of mortality end up being similar. Age, low ejection fraction, prior stroke, EKG changes, myocardial infarction, and of course here is the biggest one of all, major bleeding. So we can pretty much make a model and predict who is going to do poorly from a bleeding standpoint based on some of these parameters. And they're pretty easy to actually get to know once you, because all the studies show basically the same thing. So here's another trial, the Crusade trial, and again, using a risk stratification, what they found was that regardless of what your risk was of bleeding, if you use more than 2 antithrombotics, let's say heparin and integralin, or Plavix and heparin, your risk of bleeding in the white bars is significantly higher regardless of which risk group you're in than if you use less than that. And I'm always troubled because I find that the use of IV heparin is, I think IV heparin is a very dangerous drug, and I think it's way overused in clinical medicine. I think it's often telephoned in. Patients have, let's say, an elevated troponin, for example. And I think if you look at the trials of heparin, in at least in coronary patients, you find that there's a small margin of benefit in adding heparin to aspirin and nitrates, but it's offset by a significant increase in bleeding. And I think that people use way too much heparin. I think they still do to this day. And so I think limiting the number of blood thinners that you have to use some blood thinners for patients who have clots in their hearts, obviously, but using too many or overdosing them is a very avoidable cause of bleeding. So this slide I wanted to point out, I think it's an important slide because what it shows is even if you don't bleed, your in-hospital mortality is elevated if your bleeding risk is higher. So these patients here didn't bleed at all, but they had a high bleeding risk, and they still were more likely to die. Now, if they bled too, that was even worse for them. But the point is that even if you get rid of all the bleeding, the higher risk patients are going to do worse because they're by nature a sicker population of patients. This just shows that you can actually develop a bleeding cohort that matches very much what you predict would actually happen. So what they did was they developed a way of scoring patients' bleeding risk, and then they tried to validate it, and they found that their validation score matched up almost exactly what the predicted bleeding risk was. And if you're a fellow at Washington University Hospital, you have to enter the data on every single patient. So here's one patient, for example. They just ask you for some basic data, including their GFR, their hematocrit, heart rate, signs of CHF, and their gender. And this particular patient had a Crusade bleeding score of 58, and a risk of bleeding was almost 16%. So obviously this is a patient to be very, very careful about instrumenting and very, very careful about giving anticoagulation to. So changing course here a little bit again, all this bleeding and all these studies showing how bad bleeding is led people to start looking at some ways in which we can reduce the risk of bleeding in hospitalized patients. And there are not a lot of trials between drugs, but I'm going to point out 2 in particular that got a lot of attention in recent years. One is the OASIS 5 trial, and what they found was that fondaparinux, which I'm just going to call Rixtra because I can't pronounce this very well, is better than enoxaparin, which is Lovenox, which you probably are all familiar with. I don't know whether we have a Rixtra at this hospital or not. But studies have shown that some subcutaneous heparin is safer than other subcutaneous heparin. This was a large trial of 20,000 patients. And what they found was that in virtually all patients of all subgroups, that Rixtra was safer than Lovenox in terms of bleeding events. So bleeding was less in virtually all subgroups of patients. And in fact, it was 40% less. And on that basis, a lot of hospitals adopted the use of Rixtra over Lovenox, including the hospitals that I was on staff at in Southwest Florida. Now recently, Lovenox has made a comeback, so I think it went generic and it's a lot cheaper. And so I think that a lot of hospitals have gone back to Lovenox and have abandoned Rixtra. But this is the kind of example of a trial where somebody actually said, bleeding is a problem, let's find a better drug or a better way to prevent this from happening. And this was one of the few trials that really stood out because they were equally effective at preventing ischemic events, but there was 40% less bleeding. That's got to be a good thing, right? Because we see how dangerous bleeding is. A second trial, was an important trial in cardiology, was the Horizons AMI trial, and that was a trial of bivalirudin, otherwise known as Angiomax. So Angiomax had a really good run for several years because this trial showed that there was a significant reduction in major bleeding and a significant reduction in events as well as mortality if you used Angiomax instead of heparin in the cath lab. And actually, it was a comparison of Angiomax and heparin plus integralin or another 2B3A agent. And the findings are really striking because the reduction in bleeding and the reduction in mortality, this is major bleeding events and this is all complications, was very, very large. So you had a 4% or 3.5% absolute reduction in bleeding, but a relative reduction of something like 40% or so if you used Angiomax instead of heparin. Now, Angiomax is a lot more expensive than heparin. And so, Angiomax for a while there was being used willy-nilly, and lately heparin has also made a comeback, I think in part because of cost considerations, but also because of a recent European trial that showed that heparin may be just as good if you do it carefully and you do a lot of risk procedures. So, in this particular trial, Angiomax came out ahead of heparin, and importantly, the only thing that was worse about using Angiomax was that there was a higher rate of acute stent thrombosis, which cardiologists really don't like. That means that your stent closed down acutely, and that carries a very high mortality. Luckily, it wasn't very common, and it was offset by the significant reduction in major bleeding from using Angiomax. So if you look at it graphically, what you see is that the acute stent thrombosis rate was much higher in the Angiomax group, but the overall clinical event rate was lower in the Angiomax group. If you put all the things together, bleeding and acute stent thrombosis and everything else, Angiomax came out way ahead. But again, Angiomax being more expensive than heparin, its use is being somewhat discouraged lately, and there's been some recent trials that show that heparin maybe just got a bad deal in this trial. So depending on which cardiologist you talk to, I've always used them both. Lately, I've been getting away from the Angiomax and using more heparin. I'm trying to be a good citizen, but it's really hard to ignore the results of this trial that show that Angiomax is probably the safer of the two drugs. And of course, this is the same trial just showing that all subgroups benefited from using Angiomax over heparin. So, conclusion of part one of my talk is that there's a strong relationship between major bleeding and death, but it's not clear that stopping all the bleeding is going to stop all the deaths, because just being at risk of bleeding increases your mortality. But it's clear that preventing bleeding is going to be beneficial, and some of the ways that you can do it are some of the ways we just talked about: using the right drugs, instrumenting carefully, using your procedures very carefully, and making sure that you take meticulous care of the patient, observe for bleeding, and make sure that you prevent it and treat it aggressively when it happens. Now, part two is talking about acute tubular necrosis and renal failure associated with contrast. So a couple of features about contrast nephropathy, or CIN as they call it, is that these patients usually have normal urine output, so you won't know they're having a problem unless you're checking their creatinines. That could be a problem, for example, in outpatients. You may find some proteinuria and some granular caths on the urinalysis. This is a granular cath here. That's evidence of acute tubular necrosis. I was just in CCU a few minutes ago seeing a patient, and he's having acute tubular necrosis, and he's got a muddy bag of urine in his Foley. And if you looked at it under a microscope, you would see a bag full of this stuff in his urine. And that muddy appearance is very typical of somebody who's having acute renal failure. So these patients have a low fractional infusion of sodium, and you want to exclude cholesterol embolization. I don't want to talk about this too much because there's nothing you can do about it. It's a disaster when you have a cholesterol embolization syndrome. Have any of you ever seen that before? It's a nasty complication of cardiac catheterization. And usually the emboli go everywhere, not just to the kidneys, but also to the toes and the fingers, and that's usually irreversible renal failure and a very, very poor outcome. So the only way to avoid this is choose your patients carefully, look out doing old men who smoke, and don't catheterize them only if you can. These patients usually have peripheral vascular disease, and you unleash or you dislodge a big piece of cholesterol from their aorta, and it just goes everywhere. Really nasty complication, which unfortunately doesn't have a good outcome. But luckily, contrast nephropathy generally does have a better outcome. Over the last few years, contrast nephropathy has decreased in incidence from about 15% to 7%. Why? We're hydrating patients better. We're taking better care to look for these problems. We're avoiding nephrotoxic agents like nonsteroidals and overuse of diuretics. And we're using lower osmolar contrast media to prevent this from happening. And I'll show you a slide briefly in a minute that just shows that the newer contrast media are better than the ones I used when I was a fellow, which was called HypAche, which was hyperosmolar contrast. We used it routinely, but we now know that low osmolar contrast is much safer, and I don't think anybody uses HypAche anymore. I think it's been taken off the market, as a matter of fact. Interestingly, in spite of the reduction in incidence, the total number of cases have not declined because of the increasing number of procedures. I'm not sure if that's true anymore. I think the number of procedures in this country has plateaued, but it rose rapidly over the last 20 or 25 years with the introduction of PCI and other procedures. So just like bleeding, if you develop nephropathy, you're going to have a worse outcome. So in patients who don't have any kind of renal problem, their mortality is low. If they have any kind of renal problem, their mortality is high. If they end up on dialysis, their mortality is horrible, just like you might expect. But just like with bleeding, most of these patients don't die of renal failure. They die of their coexisting comorbidities, including bleeding. So these patients really have a lot in common with the bleeding population as well. And again, in patients who develop any kind of nephropathy afterwards, the risk of death basically went up almost 20 times compared to having no contrast nephropathy. So again, it's a marker of a bad outcome. And again, these patients don't die of renal failure. They actually are a sicker cohort. They tend to have more CABGs and have more CPK rises, develop shock, cardiac arrest, and so on. These are patients who are sicker to begin with. The renal failure isn't necessarily what's killing them, it's just a marker of their risk. So just like with bleeding, how you define renal contrast nephropathy makes a difference. If your creatinine goes from 1 to 1.3, the incidence of that is pretty high. But if you tighten your criteria a little bit and say it has to go from 1 to 1.5 or go from 1 to 2, the incidence goes way down. So again, how you define it is going to decide for you how frequent it really is. Importantly, there's a major economic impact with contrast nephropathy because the patients almost always have to stay in the hospital longer to get this under control. Only a small number of them end up on dialysis or have permanent renal damage, but the average cost, at least in 2007, was about $12,000 for the first year. I think you can easily double that based on the current rate of medical inflation now. So every time somebody has contrast nephropathy, you're costing the healthcare system probably about $20,000 in additional days in the hospital. So that's an important economic consideration. The pathophysiology is frankly kind of boring and not well understood, but the three mediating factors are medullary ischemia, direct tubular toxicity, and tubular obstruction. And the common thread of all of this is you want to minimize contact of the offending agent, that is the contrast, with the kidney cell by flushing it out as quickly as possible. So the important thing is make sure the patient is well hydrated, hold off on their diuretics, or use as little diuretics as possible, use low osmolar contrast media, and keep the cases short and sweet. Get them in and out of the lab. Don't do multi-vessel intervention on an 80-year-old patient. Do it over several days or even bring them back a week or two later and divide up the contrast use to avoid this from happening. So the main thing is get the contrast out of the kidney, flush it out with IV fluids, have them drink fluids after the procedure, etc. But make sure the patients don't have that contrast sitting in their kidney for too long because this is what ends up happening. It's a poorly understood syndrome. Nobody really understands exactly how it happens. I'll spare you some of the details, except to let you know that it's a very complex procedure, which may include oxidative injury from iron, nitric oxide production, endothelins and other hormones, adenosine. So you can see that when you see all these words and all these unfamiliar phrases, it means that nobody really understands how it works. So, the postulated pathophysiology, basically, as I said, you get vulnerable kidney cells, contrast enters the renal vasculature, you get dysregulation and spasm of the arteries, you get a release of inappropriate hormones, you get sustained intrarenal vasoconstriction, as well as direct cellular toxicity and acute kidney injury. So again, get that contrast in and out as quickly as possible and use as little as you can. Risk factors, modifiable, non-modifiable, cumulative contrast volume. That includes not just your procedure, but the procedure they had in the ER. Let's say if they had a CT of the head with contrast, you want to make sure that you minimize contrast volume across the entire hospitalization. Make sure your patients are very well hydrated. My habit is to start intravenous hydration on all of my patients in the cath lab in the holding area immediately at 125 cc's, and I use normal saline. I don't use half normal saline. And you want to make sure that you get rid of the nephrotoxic agents like NSAIDs, gentamicin, diuretics, things like that. Now, unfortunately, these patients who have high risk for nephropathy are exactly the kinds of patients that we see. Remember, there's no swans in the sewer. So they're diabetics, they have kidney disease, they come in with shock and hypotension, they're elderly, they have congestive heart failure. If you don't cath these people, they're going to die for sure. So we accept that these patients are at high risk, and we accept the risk. There's nothing we can do about these. That's why they're called non-modifiable risk factors. And of course, you can develop a score just like with bleeding, and it's very, very reliable, and exactly those elements: hypotension, intra-aortic balloon pump use, CHF, patients with pre-existing renal disease, age, anemia. We have no control over any of these things when they present, except for contrast volume, and that only gets you 1 point per 100 cc's. So most of the risk factors for renal failure after a cath are out of our control. The only thing we can decide to do is not to cath them. And you can see here, using the same score, you can see that if you get less than 5 points, your risk of contrast nephropathy is 7.5%. Risk of dialysis is almost nil. But if you get into the score where your points are 16 or above, your risk of contrast nephropathy is over 50%. Risk of dialysis is very high, 13%. Those patients don't do very well. So unfortunately, you can risk score them, but you can't elect not to cath them often because they're often in cardiogenic shock, and if you don't cath them, the risk of death is virtually 100%. So several risk reduction strategies have been evaluated over the years. I'm not going to go through all of these in any detail. I'm just going to show the ones that work and one that doesn't. Okay, so some of you are familiar with Mucomist or N-acetylcysteine. It was a popular thing to give to people before cardiac catheterizations. It doesn't work. The use of it was based on the fact that it's cheap, easy to obtain, readily available in the pharmacy, and some small studies showed benefits. But when they started doing larger trials, it proved to be very disappointing. So the only things that turn out to be effective at preventing this from happening that you have any control over is giving the patients lots of fluids, particularly IV normal saline, and minimizing your contrast exposure. Alkalinizing the urine doesn't matter, doesn't do any good. Statins, no convincing evidence, and all these other drugs and interventions. I've seen some of these used before, they don't work. And some nephrologists still do a lot of this stuff. They still swear by it, but the evidence just isn't there. So here's N-acetylcysteine meta-analysis, and what you see is that the trials are all small and they're all over the place. But one or two of these trials look very promising, and based on that, we started giving N-acetylcysteine to everybody. So somebody finally decided to do a randomized controlled trial of placebo and N-acetylcysteine, and they found that the nephropathy rate, the creatinine elevation, the doubling of creatinine, the mortality, the cardiovascular mortality, the need for dialysis, the mortality or need for dialysis was exactly the same, and nobody knew what they were getting. It was a blinded trial. So all bias is removed, 2,000 patients in this trial, and this convincingly showed that Mucomist just doesn't work. It's too bad because it's easy to divide a GNC. And this is just a graphical form of the same thing. No benefit. So just looking at osmolar contrast, and this is a little bit boring, but I'll just summarize by saying that in 31 studies, basically they found that the pooled data showed significantly less contrast nephropathy using omnipaque or some of the lower osmolar contrast media. They're more expensive, but they're so much better that it's pretty much unethical now to use hyperosmolar contrast, and I don't think anybody does anymore. Your reduction in rate of risk was about 40%. And when you pooled all the studies together, that's pretty much what you found. And when they tried to look at ionic versus non-ionic contrast, there was really no difference. So it really comes down to using low osmolar contrast. IV fluid, I'll just say a few words about that. It protects against nephropathy in two ways. You expand the intravascular space and reduce vasoconstriction, and you reduce the direct toxic effect of the contrast on the kidney by minimizing its contact by flushing it out faster. One study looked at half normal saline versus mannitol and furosemide and found that half normal saline was better than giving all of these interventions. And then Trivedi looked at half normal saline versus normal saline, looked at normal saline versus oral fluids and found that that wasn't even close. People who got normal saline had a much lower rate, like 10% the rate of patients who were just told to drink a lot of fluid before their heart cath. So that's pretty much of no value. Some patients drink a lot of water. I tell them to drink a lot of water after the cath, but beforehand it has very little value. One study looked at normal versus half normal, and normal saline came out ahead by about 50%. So you want to use normal saline, and how much do you give? You give as much as the patient can tolerate. Don't put them into heart failure. We put them into a little bit of heart failure to avoid nephropathy. Just make sure they intubate them, please. So when you boil it all down, and I'm coming to the end here, I promise, this is what you should do to prevent renal injury. Class 1 indications based on the evidence. You should assess all patients for risk of contrast nephropathy before PCI, right? All patients should receive preparatory hydration. So I've been talking to Cal about making sure we start people on IV fluids on arrival to the cath lab to make sure we got the fluids running. It's not practicable to do a cath at 8 o'clock in the morning, bring them at 3 o'clock in the morning for 5 hours of hydration. So I give them 125 cc's an hour for a couple of hours, and we do the heart cath once it's an emergency. And I let their blood all the way through the procedure and all the way to the end of the procedure when they go home. So they get something around a liter for an outpatient cath for about 6 hours, 125. That's almost a liter of fluid that they're getting. And I think that's pretty good. Then I do tell them to drink a lot of fluid when they get home, because what else am I going to do if I send home with an IV? Patients who have chronic kidney disease, and really any patient, you should always try to minimize the volume of contrast media. That's all that we've got. Those are the only things that are based on evidence. Hydration, minimize contrast media, and make sure you know what the risk factors are for it. No benefit, mucomist. Not useful. So recommendations: manage medications, manage volume, use the right contrast media, and follow up as appropriate with resuming metformin, nonsteroidals, et cetera, rechecking in the office to make sure the creatinine didn't go up. So winding up, nephropathy is associated with worse outcomes, but importantly, there's no causal relationship. So if you reduce nephropathy, you don't necessarily improve outcome because it's the risk that's more important than the actual nephropathy. But it still makes sense to try to reduce it, prevent it from happening if you can. There are so many different studies with inconsistent inclusion criteria and results that basically all we know how to do right now is hydrate, avoid toxic drugs, and minimize contrast line and use low osmolar contrast. There's no conclusive benefit for any intervention except those two things. So, my last slide, putting it all together. Careful patient selection is paramount. First, do no harm. I've started treating my older patients much more conservatively than I used to. I try beta blockers first, and I try to get them on nitrates. I'm much less quick to taking them to the cath lab. I think that most cardiologists are doing the same. I think we're starting to respect how much harm we can do from bleeding and nephropathy, and we're trying to make sure that our more frail patients are treated conservatively. And it's only those who fail conservative therapy that we then take to the cath lab, regardless of their age. Bleeding and renal failure mostly reflect patient frailty. So it's not the bleeding and renal failure that gets them, it's their tendency to bleed and have renal failure that's so dangerous. Keep your procedures short and sweet. I don't know why people have to IVUS every artery and they put in 9 stents, and that's not how I practice. I put in 1 or 2 stents, and any more than that, I bring them back. I think it's really important to divide up your procedures, especially in your older patients. minimize your contrast volume. That's key. Stop offending agents, non-steroidals, diuretics, unnecessary blood thinners. Hydrate the patient, like we talked about. Meticulous attention to technique, and I may end up doing radial procedures in the future after all, based on the emerging data. Consider using better drugs as available. So the evidence suggests that Elixir might be safer than Lovenox, and Angiomax may be safer than heparin, depending on which study you want to look at. And minimize anticoagulation. Be really cautious with heparin. It's a dangerous drug. I think it's overused. Thank you very much. Any questions?
I have a question from an emergency perspective.
Sure.
Well, first, is there much evidence showing like a before versus after fluids, the benefits before and after the cath?
I think that most of the studies looked at prehydration, obviously. So if you know a patient's going to go to the cath lab and they have an elevated creatinine, it's obviously better to start them on the fluids right in the ER on the way to the cath lab. That often gets overlooked because you have so many other things you have to do on that patient. You have to get them on their oral agents and get them on their integralin and their heparin bolus and get them in one piece up to the cath lab. So, but if you have a chance, starting some IV fluids is usually a good idea if they're not overt heart failure. It's almost never going to hurt them. And if they come to and they start coughing up a little pink froth in the cath lab, I just give them some heparin or some Lasix and I just turn off the fluid. So I'd rather keep them a little on the wet side than the dry side to avoid later complications. But I understand that a lot of times there's a lot of smoke in the room and it's really hard to think of doing that.
Yeah. And then the anti-platelet agents, what's your sort of feeling on the use of Brilinta, Epian, Plavix in the ER versus?
I like Brilinta in the ER. Give 180 and you're done. It works within an hour or two. Plavix can take up to 24 hours. And so I don't think there's any place in the emergency room for Plavix anymore. That's my opinion. There's a lot of old data, the Crusade trial and so on with Plavix, but I think the newer agents are clearly faster. They don't have to be metabolized in the liver. And so you get full antiplatelet effect within hours, not days. I like Brilinta better than I like Epian because Epian has a bunch of black box exceptions. People over the age of 70, less than 60 kilos, any prior TIA or strokes, that excludes a lot of patients right there. So it's just easier if you can have one drug. I like Brilinta for that reason because there's so many black box exceptions. Epian works great, but I just think that because of the exceptions, it's just easier to stock one drug and get familiar with it. So I think Brilinta is the one right now.
I've given Brilinta before, and he had a cardiologist kind of say, well, that's, what if he needs a surgery? I know that the surgeons are a lot
that's true.
more nervous about it. So
right. Well, the use of, and this is a consistent across all the trials, consistent finding is that when you give people oral antiplatelet agents, Plavix, Brilinta, or Epian, the rate of surgical bleeding is much higher. It's like triple. So surgeons hate Plavix, and now. What percentage of patients that come with acute coronary syndrome have to go for surgery urgently? About 10%. So you can stabilize 90% of them, put in a stent or a balloon pump or whatever, but surgeons are a picky bunch and they'll often make the patients wait to have the surgery because they got Plavix and they'll make them wait 5 days. I don't know how the hospitals get paid for that. I bet you they don't. But some surgeons just bite the bullet and they just operate. They have to operate. And they say, well, they're on Plavix. And your chest tube output triples if you take Plavix. So they don't like it for that reason. But I think you're thinking too many steps ahead if you avoid it in the ER. So if somebody's having an MI, if you want to give them integralin instead of Brilinta or Plavix, that's probably just as good because then you can stop it and it's gone in 4 hours, and surgeons like that better. But if you want to do something quick and dirty, give them 2 Plavix tablets, and by the time you get to the cath lab, they're pretty much therapeutic. So it's a judgment call on your part, and there's no right answer because you're going to get yelled at either way, so you can't. I personally think that the guy in the ER should make the call because you're the one with the patient, and you can't worry about downstream whining. You're doing what you can to help that patient right then and right there, and if the surgeons don't like it next week, tough. So that's how I look at it.
Yeah.
Any other questions? Yes.
Same thing, ERs, and the heparin bolus. Recommend that?
I like a heparin bolus. We're going to give them heparin whether you give it or I give it, so why not just give them the ER? No need to start a drip. So, you can give them, 50 to 70 units per kilogram, wherever you feel comfortable doing. I'll probably check an ACT once I get sheath access and give them more if they need it, or start a 2B3 agent. If you have time to start a 2B3 agent in the ER, I like it. There's not a lot of evidence that 2B3As are useful in upstream use for STEMIs. For ACS, there's no question that if the patient has ST pressure and non-STEMI, there's compelling evidence that integralin reduces mortality by about 50% and reduces morbidity as well. So I think that we should use more IV antiplatelet agents like integralin. For STEMIs, even though there's not a lot of evidence, I still think that if you don't start, I'm going to start it anyway. When it gets to the cath lab, you get less bleeding with a 2B3 as you do with heparin. So I'd say a heparin bolus, a 2B3 if you have time. You decide about the oral certainly aspirin, we all agree with that. But the second agent, I prefer it because I'm the cardiologist, I'm not the surgeon. But if Dr. Schulber was sitting here, he'd probably have a different opinion about it. You know, he's not here, so. Hope that helped. Well, thank you all for coming.
So did you catch him, Susan, before he left?
No, I didn't. I thought he was coming back in.
I think he said, yeah, I wonder if he ran into the final.
I think ours was a policy issue. I think we're still working on it. I feel good at where we're headed with it. But for this, we've got at least a sentence in there.
So, Clyde, do you want to track it?